I'm going to be getting going now on a second topic, which really is forward-looking, seeks to talk about what I believe will be a very big trend within dynamic modeling over coming years. It's already shaking up aspects of health service delivery and more sort of service components of health, but is increasingly being talked about in the context of digital epidemiology and the, quote, big data revolution for health sciences. And what I want to highlight today is how that set of trends, which are undeniable, substantive implication, and not in the future, but are really in the present, how that's likely to intersect with dynamic modeling. Okay, the dynamic modeling that we do today and the dynamic modeling that we will do in 5 years' time is very, very different than the sort of presents very, very different opportunities for empirically grounded modeling than when I first started applying dynamic modeling to social and decision problems 25 years ago, but equally extremely different from when I first started really making my big forays in health 15 to 20 years ago, and even very different from what I've seen in the past 5 years ago. Things are changing very quickly with respect to availability of data, and if you go out there and listen to what some leaders in the health modeling field are saying now, they are recognizing that increasingly we are headed into an environment where a lot of the data needs of models are now need to be navigated within the context of a much more data-rich environment. So I'm going to be talking within this lecture about some motivation and context for this sort of work, give you a glimpse of some of the needs that I see as very keen for data coming from the big data side, talk a little bit about the characteristics of big data, and talk about one particular system that we've been working on for the past 6 or so years, the so-called IEPI system, which is a sensor-based survey and crowdsourcing system to inform understanding specifically on the epidemiology health areas, and with a particular focus of building that system and use of the system to inform models, okay, to inform dynamic models. And I'm going to be talking about the data implications of combining dynamic models with this data and using machine learning techniques such as particle filtering, and then give a brief vignette as time allows about why I believe this sort of data may not be simply a luxury, may not simply be a great opportunity in the dynamic modeling area, but may for certain types of research questions be a necessity to get accurate results from models, and indeed to come at accurate understanding of the situation at all. And then I'll end with some conclusions. In contrast to other presentations, this one will be less heavy in terms of, I don't anticipate opening any models here. So Annie and Dylan can rest easy. The context of this work is reflective of the fact that my modeling group invests most of its modeling efforts in what I would sometimes call empirically grounded models, or decision-oriented, sort of richly informed simulation models. And these stand in contrast to another tradition, which you'll see very represented in dynamic modeling called stylized modeling, or modeling for theory, or etiological models that seek to kind of understand how very simple mechanisms can combine to yield explanations for patterns we see in the world, to help alert us to gaps within our interventions, the need to enhance our understanding of how our interventions work. Stylized models are very common, and they are perhaps, if you look historically, the biggest used of agent-based models. in particular. They're also prominent within the system dynamics area. But a lot of our work, particularly for the Ministry of Health, work with Alberta Health Services, work together with a wide variety of partners in the States and in Canada, is really focused on empirically grounded models. These are models that go beyond sort of seeking to understand the implications of several small, simple assumptions for system behavior, but instead they really try to grapple with a fairly articulated representation, textured representation of some external specific health context. Maybe it's the city of San Diego, or maybe it's an aspect of red deer in Alberta. And they seek to understand how the dynamics of that environment across multiple processes shape health evolution with respect to certain health burdens. So whether it's communicable, chronic diseases, zoonoses, a lot of our models are really designed to inform decision-making in health at a quantitative level, to provide that understanding about which interventions are likely to yield the biggest gains. And in order to do that, we need models that are informed by data. So many uses of these sorts of models involving human health and behavior require or really benefit from copious data sources. And we have to undertake that data incorporation of the model with the recognition that we are looking into counterfactuals where the data will be different, but we want to often tie down areas of our model out of the realm of speculation if possible, and actually tie them down with empirical understanding. And these models, particularly individual-based models, which provide detailed longitudinal and cross-sectional views of a population's health over time, are very rich, but they do provide many pieces to them. And if you're trying to understand, patient flow through Saskatchewan's care system and its interaction with population health, or if you're trying to understand the spread of pertussis in centers and rural regions within Alberta, you are going to be concerned with a variety of processes, both demographic, having to do with mixing patterns between individuals' choices with respect to vaccination strategies and catch-up strategies, their risk perception with respect to outbreaks and how that changes both vaccination behavior and mixing behavior, etc. So in this case, we're often articulating with hybrid models and with the toolkits that are available for each individual tradition, broader and more detailed models that involve more articulated theories of the world. Now, a major barrier in this area is that reliable understanding and data, both understanding the theory and the data on key health behaviors in these models, are often hard to secure. So, we're often positing behavioral influences, say, of the influence of the built environment and location as it affects someone's physical activity, or how certain distance of access to certain resources, such as parks or food environments, affect people's shopping behavior for food. We're interested in physical activity, spatial proximity of individuals, transmitting norms, communication, transmitting weight, sort of norms concerning weight, but knowledge, attitudes, and beliefs on both spatially proximate individuals in the context of social context, in social context. We're also interested in the impact of the communicational environment. I'm privileged to work with a leader in this field in the States, Vish Vishwanath at the Harvard School of Public Health, who focuses a lot of his work on this issue of health communication and how personal media consumption and mass media shape people's decision-making, whether it comes to choice about vaccination for things such as HPV or influenza, or whether it's factors that govern people's perception of risk or lack thereof concerning tobacco use. And I've also mentioned our sustained interest in this issue of how people make decisions at the micro level. How do people's decisions in terms of health behaviors, in terms of the amount of time they invest in moderate and vigorous physical activity, in terms of their sedentary behavior, how are those affected by the environment around them? How are they affected by the choice sets that they're presented in terms of spaces in which to exercise? And how is their food-going behavior affected by this, their eating behavior? Those are just some of many areas in which we're involved. And what we find is, in case after case, absent understanding of behavior at these micro levels, the potential for quantitatively evaluate policy trade-offs is limited, to do so with great accuracy. Now, this is in the context of a lot of additional challenges that I won't go into, but which certainly are very much on the mind of multiple partners, particularly the difficulty of reaching traditional vulnerable and underrepresented groups to understand their particular challenges. It's not merely a matter of understanding the behavior of the average person in the population. There are real disparities in terms of the health burdens associated with chronic disease and in terms of health behaviors. And sometimes those who are in the most vulnerable positions and have the most adverse patterns associated with health behaviors are ones that are hard to reach via traditional surveying strategies. There's also a very strong interest in understanding kind of exposures that an individual encounters in the course of their days. And we know that a person's postal code address and work address are often fairly limited in giving an understanding as to their activity spaces, to what things they're exposed day in, day out outside of those environments. And we know that people's self-reporting is often quite unreliable when it comes to many of these factors we mentioned here. We know since the NHANES 3 study that there's big gaps between what people self-report in physical activity and what is actually measured through things like accelerometry and heart rate monitoring, etc. We know, moreover, in terms of food consumption, that people also have a hard time accurately reflecting what they've eaten over the past month or over the past year. We know in terms of reporting their social context, there's a big gap between who people report being near and who they're actually near. And in terms of spatial circulation, we also find very large gaps between self-report and what physical measures suggest. These are very big accompanying challenges if we wish to inform models that have articulated theories of people's decision-making and day-to-day behavior. If we're trying to characterize people's use of e-cigarettes versus regular cigarettes and how those are weaved together, or if we want to understand that food procurement types of patterns or physical activity and sedentary behavior, we often find ourselves coming up short with traditional instruments, traditional data sources and literature to really inform an understanding. Much of our interest here, though, is focused, as it often is, in the intervention context. And I mentioned this case to Colin earlier in response to a question about this very real challenge when you have an intervention in effect, say a coarse-grained intervention such as a move of a family from a lower-income neighborhood to a mixed-income neighborhood. That ripples through, ultimately, perhaps to measurable outcomes that are, again, rather coarse-grained. Things like changes in obesity levels and changes in criminal involvement as measured through arrests or other records in the criminal justice system, and likelihood of high school graduation. But often what we're really interested in is understanding what goes in between these. What's driving the lower obesity levels seen among teenage girls in those who have moved from lower income to mixed income environments? To what degree is it aspects of neighborhood walkability and sedentary behavior, perhaps mediated by time spent at home? To what degree is it amount of moderate to vigorous physical activity that they're getting? To what degree is it a factor of, for example, the time that they're spending at home leading to changes in their eating patterns which again ripple through to obesity levels. To what degree is the healthy food environment, how much of a role is that playing, and how much of it is just they're spending more time at home eating mom's cooking rather than McDonald's, and therefore they are, it is affecting their BMI predominantly through this pathway, the food environment, versus through the pathway of time spent at home. We can ask about these things, and there's no shortage of questions that people have posed, but the accuracy of self-reporting for a lot of these factors here is really questionable. And particularly when those surveys take place, every 6 months, after a long period of time, and particularly when there's declining response rates to those surveys, and factors that we've relied on for risk factor surveillance, such as random digit dialing, are becoming increasingly untenable as a way of reaching out to the population. So a lot of our partners in this area are very concerned about the inability to really probe issues concerning health behaviors accurately using self-report and using traditional means of interacting with individuals through telephone surveys or direct door-to-door interviewing. Now, within the context of this work, there's been a simultaneous rise in the interest in and availability of what is often called, using the rather overhyped term, big data. This is an overhyped term, but it's a term that I believe has profound implications for modeling and indeed for health research that are not overhyped. I prefer to go by the name data science related to us, but the point is that increasingly we have available to us within the health sphere a growing amount of data that can inform our understanding of health patterns. Inform our understanding of health patterns in some cases with physical measurements, such as using sensing data, data from sensors such as Wi-Fi, GPS, Bluetooth to capture individual proximity, and measures that will help us understand the indoor and outdoor environment. I'll be talking much of the time in this lecture about that. But also data having to do with social media use, where there's remarkable amounts of data posted by individuals reporting their status. Increasingly, we live in a world with very rich environmental sensors, and buildings such as this one are typically accompanied these days, newer buildings, by extremely sophisticated systems that measure the indoor environment. And externally, we have all sorts of sensors that are being used to pick up things like nitric oxides and sulfur dioxides, CO levels, and other factors that have health impact. But increasingly, data is available electronically at things like lab test results. It's data that one of my students is working with back in Saskatchewan, in which many of my colleagues have used to good effects. Point of sale data from stores, administrative data from large-scale administrative databases, say for population-wide patterns concerning diagnoses and prescriptions and procedures, and questionnaire responses that are delivered through less traditional means, such as mobile devices and web. Again, an area I'll be hitting on quite a lot. Also, sort of patterns associated with calling behavior, communication infrastructure data, such as proximity to cell phone towers that can be measured, and online health behavior browsing data also being of interest. So increasingly, when it comes to understanding health behavior, we have recourse to a growing amount of data sources that can provide some level of insight. These are not merely small in their impact. They really address things that are sometimes called the 4 V's of big data. On the one hand, volume, and that's the one that people pay attention to. There's just so much data out there being posted on Facebook or being posted on Twitter, status updates that people make about their relationship status or their happiness or what have you. But what's actually more significant, I think, in the dynamic modeling context, the velocity of that data. It comes in very quickly. It's high resolution at a temporal scale. So it may come in every few minutes with data from sensors. It may come in many times a day for Facebook updates. It also is very notable for having a variety of data. It's not just one error-prone source alone. It's a bunch of sources. And while each of them is incomplete, each of them is error-prone, together there's a certain amount of triangulation you can do to get a picture of to what may be going on. And finally, for certain types of physical measures, things like accelerometer readings, heart rate readings, which are increasingly available through tools such as Fitbit, the Apple Watch, Empatica products, device coming out from a number of manufacturers. Physical measures are less subject to self-reporting bias. And even if you get someone to snap a photo of their food, it's not subject to the type of recall bias that memory normally would be a month hence or 6 months hence. So we've been building up for the past 6 years a platform which is now in its third generation for helping to collect this sort of information. Not only information from, it's a smartphone-based app for one portion of it, but increasingly it reaches out to data from these other data sources here and cross-links it with this data. So for example, cross-linking with weather data, or data from smart watches, data from weight scales, etc. This particular system that I'm going to be showing you here has a very notable sort of app component. It's right now an Android app, but there's a plan to roll out the iPhone version on top of ResearchKit sometime in late spring, and we're very eager to get that out. People install it on their own smartphone and can carry it, and it provides a way of asking, not only collecting sensor data, but asking context-triggered surveys and crowdsourced information that the user can report. So we have a wide variety of partnerships. This is only a fraction of them based on what's gone on the past year, which has been really big. Broadly speaking, there's a component of it on the phone. It uploads the data to the server, catch as catch can. When there's a network available, it'll upload the data to the server, and then we process it. And AnyLogic is one of our main tools for making sense of this data, but we also use R extremely heavily, and tools such as MATLAB, GIS tools, and others to help make sense of this data. The emphasis here is it does not count on ongoing connectivity. It just stores data on the phone for however long it needs before a connection can be obtained over which it can send the data, and then it sends the data up in a secure, encrypted fashion. The whole system was designed for the bottom up for security so that confidentiality could be guaranteed. So the system is designed to allow for reporting back on an ongoing basis. It sort of reports in data when it collects, and it's automatically updated in both the app form and the study configuration on an ongoing basis. So these are five of the areas that we try to address, and not surprisingly, these map just some of the same areas that we saw earlier that it's really hard to collect data on. We find ourselves stymied sometimes in our modeling by lack of data on these, and so we built the system in significant part to try to inform data in these areas so that we could do better modeling. And in order to do that, we make use of three broad types of information. Number one is sensors, and this includes sensors on the device, plus third-party sensors. And on the device, you may or may not be aware of the fact that modern smartphones come and their tablet cousins come filled chock-a-block full of sensors these days. Many of the more standard ones are provided here. Things like GPS and Wi-Fi, which provide understanding of your location indoors and outdoors. Information related to Bluetooth, which gives an understanding of your proximity to other individuals, and accelerometry data, which provides some understanding of level of physical activity and sedentary behavior. But you couple those things with, for example, data from smartwatches on heart rate, and you get a much better picture of actually moderate and vigorous physical activity. You capture it together with information from questionnaires or from self-reports, and you start to get a more complete picture. Just from sensor data alone, we can get understanding, for example, in concerning mobility patterns, how much time people are spending in different neighborhoods over the course of a day. We can do localization within a building to quite a strong degree. We can capture network patterns as they change literally every few minutes, but also at the level of week to week, for example. And we can capture how long people are spending together. But one of the most exciting areas that we've been using and that our partners seek to leverage is actually data delivered on the device in micro-questionnaires. So the two types of questionnaire interactions that are used. One is sort of classic ecological momentary assessment. They come in at fixed times or with a certain chance per minute of getting a survey issued. So maybe once or twice a day you'd get a given survey at a random time or at fixed times where you'd fill it out, and it will be presented to you. And these are study specific. They don't require programming to create them. They're simply encoded for the system, and we can ask people these questions on their phones. However, often we contextually trigger these. We trigger them based on where they are, with whom they are, how long they've been there, how much exercise they've gotten recently, and when they're in certain locations, we might issue a survey specific to that. So here, the information that is recorded in a study differs on a study-by-study basis as to what's in the survey. It includes conditional questions and questions that can do variable substitution going forward, but also recorded as metadata, like how long it took them to answer a given question, how long it took them to fill out the whole survey, etc. In addition to that, there's information from crowdsourcing. So on their device, they'll have buttons, and they can push those buttons to indicate things. For example, that they're feeling ill. And in a world where, for example, we're interested in foodborne illness, together with Public Health Agency of Canada in a collaboration with them, and if one of the things you have to recognize with foodborne illness is it's estimated that well less than 1% of all cases of foodborne illness are reported. Very small fraction of them are actually reported to the healthcare system. Very few people present for care at a hospital or with a physician. And in this context, we can get actually a much larger set of potential, and that's a key point, potential cases of foodborne illness by allowing people to proactively indicate if they're feeling ill. And once you combine that, you take that data and combine it with where they've been and where other people have been who have also reported feeling ill, you can start to get a sense about where there might be risks present for a foodborne illness contamination event. So in this case, for this study, for example, we had people reporting when they're ill and when they're eating. And when they were eating, they took a picture of what they were eating and filled out a bit of information about where they got that food, from where it was sourced, a little bit about where physically they purchased it. So here, there are study-specific buttons that they can indicate to press to report incidents of various sorts. So this might be, for example, they encountered tobacco messaging. That's some work with Dana-Farber and Truth Initiative. Or exposure to environmental risks, so they were exposed to diesel fumes or exposed to some adverse air quality, food consumption, or, for example, occurrence of coughing and wheezing, if we're interested in asthma. They can report when they took medicine, for example, insulin, when they tested themselves for blood glucose, take a photo of the reading, etc. So this is the primary way in which we use this system. We sort of advertise the study, interested parties view the website, and if they're interested, they install the app, enter a study code, and they fill out a pre-survey that will indicate whether they're qualified to join. Often they'll have the app ahead of time, increasingly, in which case they could just opt into another study, fill out the pre-survey, and if they're eligible, they'll have an option to then view a consent video and decide whether or not to opt into the study. And increasingly, we are looking to deploy this on large batteries of individuals out there in the population. Alberta is is aggressively trying to find between 10,000 and 100,000 people to follow on an ongoing basis for a wide variety of different studies. And American Legacy Foundation is looking at thousands to monitor the impact of their anti-tobacco advertising campaigns. So then you collect baseline data, and then often data in the context of an intervention, and that will combine sensor data, survey data, data from self-reports, and web access. And here we optionally will cross-link to other devices such as wearables, etc. To give you a concrete sense of what this thing looks like, for example, for a recreational water use study, I've done a lot of work with looking at the patterns of illness in bathers in Southern California. And here we might have the ability for someone to report, I'm going to bathe in a pond, lake, or ocean, report when they're feeling sick. Again, the vast majority of cases of gastrointestinal illness from bathing are not reported normally. And then finally, if they saw or heard a water quality advisory. So we know something about what they've encountered. So here, we might be eliciting information when they report feeling lousy. Did they see a healthcare professional about it? The nature of the symptoms? Did they encounter a fever? And were they confined to bed? Or if they encountered advisory, did it change their plans? For what beaches was it reported? And here they might report encounters of entering the water. And based on that, we can look at things like for a given beach where we know through physical measures maintained by the coastal authorities what the level of risk was in each day. We can look at when they report bathing, and we can look at when they encounter occurrences of highly credible gastrointestinal illness. We can also look to what degree they are abiding by advisories or closures during this period, and how that relates to when they seek care. So we can understand something about their microbehavior of going to the beach, bathing, and cases of illness that would otherwise go unnoticed in a way that might allow us to improve our understanding of the health burdens which have thus far been much of them latent. Or in physical activity, this is some work together with a colleague elsewhere in Canada. We might have people, for example, reporting when they weigh themselves, have them take a photo of the scale, report barriers to physical activity and supports for physical activity, and report instances of exercise, which they can comment on. But a lot of that is reported automatically by the sensors. It's picked up already, and it complements that and helps understand the motivations for exercise, why they're exercising, to accompany someone for recreational purposes, for utilitarian purposes, etc. So here, for example, we might ask the type of exercise, the motivations or goals of this activity. Was it predominantly for health or to lose weight or multiple of those? And we might ask them to take a photo of the weight on the scale. In many cases, we'll ask them to record, rather than ask them to type out records of why they're engaged in something or more open-ended questions, we'll do an audio recording. And with Alberta Health Services, we're working towards larger scale voice recognition of these components that might allow later questions to key off of them. That's a big challenge, but what we have right now, and which we've used widely, is audio recording of responses. So that rather than burdening someone with a longhand report, they can just tap the button and give a report about a barrier to physical activity or their reaction to seeing their weight, for example. Foodborne illness, again, this is the work with Public Health Agency of Canada. We can ask them about what's the source of food, what's the nature of the food that they're eating. We are getting remarkable levels of compliance in these studies because the questionnaires are so simple. There may be 1 to 5 questions at a time, and it's amazing what people are willing to do as long as it's not too burdensome within the course of the day, little reminders to get them to fill out some information. We can ask, if they're feeling lousy as part of this study, if they're saying they're feeling sick, we could ask, did we see anyone? What were the nature of the symptoms? And we have a variety of other studies that we've run that will help us sort of understand exposures, symptoms, and its relationship to care seeking, and its relationship to advisories or other components that might shape their behavior. So without going into this in detail, we've applied this to a huge number of different uses, from health service delivery needs, the movement of ambulatory patients in the hospital, for example, which can forestall a lot of questions concerning atrophy or wasting of muscles, to issues having to do with communicable illness, a CDC-funded randomized controlled trial for influenza, cases of tobacco, the burden of tobacco and messaging in tobacco, physical activity, and weight outcomes, etc. A key component, though, goes well beyond the device. The device is great for picking up a lot of the information, and it's provided us an incredible amount of information. Information in terms of compliance we never would have thought would be possible, in terms of how willing people are to share information. But beyond that, we have an administrative interface online that helps us monitor these things. This is a website. For example, we can monitor compliance of different individuals. When was the last time their phone reported data? What's the level of data we've received from each person? We can report back information on the surveys that they filled out, what they answered to each survey, and where the surveys include audiovisual components, we can link those up to the particular reporting. This was a physical activity study that, again, I'm leading with someone in Canada, but as an example of this, for this group, I was recording things here in Melbourne, and you could see that in this context, you can pick up both rich audio and visual cues, and you can also plot out on maps as a standard part of the system where different reports were received and in the nature of what was photographed in the audio from that. You can figure out where I'm spending my time. This is me out at Burwood campus, and this is me here in the city. This is a trip Jeff and I made up to Melbourne University, and some time we spent over here shopping for that audio thing, and this is my hotel, and this is, I think, right in this area is going to be the occurrence. Oh, it's this one right here, which is this room where I'm spending an undue amount of time. You could see my hotel, and then in this place here, and where I've kind of made my ways around Melbourne. You can map out activity level over geography as reported by many different individuals, capture social interaction, spaces, etc. Just going down through here a little bit, I don't have time to cover all of it. One of the most valuable things you can do is look at people's actual empirical activity spaces. Where are they spending time, and to what services are they near at different times within their activity? So if they're taking a bus back and forth between locations for work and home, where does that bring them by? Where when they're at work, or where when they're at home, where when they're out shopping? What are they coming near in terms of access, say, to grocery stores? And here we found, for example, this is showing two participants from different neighborhoods, and you'll see the difference to which they're exposed to different sorts of food environments in the course of their day. Now, all of this requires an incredible emphasis on security and confidentiality from the ground up, and that is something we built in. When we first started this work about 6 or 7 years ago, the first thing we did is went to our ethics boards and said, what can we do, and what are you comfortable with, and what guarantees do we have to put into place? And we've had a very good relationship with them over these years for dozens of studies now. And it includes on-device encryption. People can stop the data recording at any time, pause it, and resume it later. It's secure transmission in an encrypted fashion, and we censor out certain types of information that would otherwise potentially be identifying in terms of names of devices. And we can restrict who is recorded in terms of proximity to whom through Bluetooth to make sure that we're not picking up lots of non-participants, if that's a concern. A key constraint here is the energy on the device. We need to shepherd and to take stewardship of the energy, because otherwise we can drain the battery. In general, these days we're in an excellent situation. We have a pretty small energy footprint on the devices, smaller than some other apps. and often smaller than just using the device. Fortunately, device energy efficiency has been really going up exponentially, and we can take advantage of that. So what are the value propositions of this? Well, when you think about its interaction with models, it's intensively longitudinal. It has physical measurements for many things, which can provide us with firmer evidence. And you have both quantitative and qualitative responses that are cross-linked in terms of ecological momentary assessments. You have enough temporal resolution to eliminate many aspects of recall bias. People are no longer trying to remember 3 weeks ago what they ate. They're no longer trying to remember how much that, what types of physical activity they were engaged in over the last month. You can pick it up in the course of the day, and of course many of those things are measured physically anyway, where they've been, their mobility, who they're spending time with, where they're engaged in exercise. These are picked up by sensors, not by self-report. But for those things which are self-reported, it's frequent enough that you don't have a lot of recall bias, such as you might in a telephone survey or a door-to-door interview. You can recognize many day-to-day patterns and many exposures, social environments, physical proximity, the built environment, and in many cases you can triangulate from multiple measurements. Newer phones, for example, often have humidity sensors, barometric pressure sensors, and through a whole bunch of different measurands you can try to get a good understanding of someone inside or outside, which can be an important indicator for risk of exposure, say, to mosquito-borne illness or to external pollutant levels. It's automatically collected. A lot of this data is collected behind the scenes, automatically in the phone, just through the day. And it uploads it catch as catch can. If the network happens to be available, it can do it. But if a network, you're out of contact for a network for 3 weeks, that's fine too. You can reconfigure it, update the app, update the study design if required, fix those typos in the surveys at any time. And you can push content to participants based on that on a minute-by-minute basis if they're online. So what are some uses of this? Well, one of the main ones relates to Colin's question, to tease out the effects across different pathways that mediate the effects of an intervention. You can pick up the sedentary behavior, the food procurement behavior. You can tease out the moderate and vigorous physical activity and how much time you're spending at home and with whom you're spending that time. And you can get a much better understanding of those sort of set of pathways that we talked about, mediating, say, the effect of moving to a new neighborhood on obesity outcomes. You can also pick up subclinical symptoms that would otherwise go unnoticed. Think exposure to adverse water quality or air quality that might trigger coughing and wheezing for asthma that would otherwise go unnoticed. Think about those near falls or actual falls that go unreported from surfaces that are unnecessarily dangerous. Or think about waterborne illness and foodborne illness. A lot of those things are latent, not reported otherwise. And here you can connect those cases of subclinical reports to exposures. Exposures to outdoor environments with air pollution, to fast food environments, tobacco promotion, etc. And you can better understand thereby the effects of potential intervention on an individual. And you can pick up aspects of the social and physical environment, allowed for crowdsourced reporting, their perceptions. These are things often included in qualitative research, right? Their perceptions of barriers to health, their indication of why they engage in physical activity. You can pick those up in the moment shortly after that activity. You can pick up motivations, protective behaviors, and risk behaviors and aspects of risk perception. Trace movements of individuals to healthcare facilities, recording exposures that can be retrospectively examined in case later adverse health conditions are developed, and secure more reliable information on risk factors and influences that are less reported by self-report. And then capture information on cognitions and affects just after exposure, say exposure to tobacco billboard, such as we're working with American Legacy and Harvard. What does all this have to do with models? Sounds interesting, but what does it have to do with models? It has everything to do with models. it turns out to make sense of this sort of data, to really turn it into value, to yield actionable outcomes and findings from it, we need models. And we need 3 different types of models, broadly. Some are sort of machine learning models that classify someone, that can help us recognize, using sensor data, is someone smoking? Is someone engaged in moderate and vigorous physical activity? Is someone likely to be using an e-cigarette? There's also inferential models that can help us deduce where someone in a long-term care facility might be getting infected from, but also dynamic models. And it's really this last one that I'm going to emphasize here. So simulation models here are used to characterize sort of a way to make sense of how this data relates to intervention outcomes. And I have a better slide on this that I have in a few minutes here about the role that simulation models. And I apologize, but I think it's there. It is. Yes. So the ways in which this data comes together with dynamic models are as follows. So basically, the data from these devices provide a key source of information to develop dynamic hypotheses about what might be going on. If you actually have data about people's food-going behaviors, we can take that sort of understanding and better craft the sort of state charts we built up yesterday, right, concerning how people go to the grocery store or a convenience store. To what degree do they really wait until their larder is empty? To what degree are they going opportunistically during the day? Are they really going from home or from other places? We always had them going from home. Maybe that's that's a mischaracterization. But also, these sort of data can provide very valuable information for parameterizing a model. How frequently do they engage in certain behaviors? What's the nature of their contact network? To what degree does that change over time? And critically, we can capture preferences. The sorts of information we capture on the phone, both in terms of stated DCE instruments, stated preference. We can issue surveys on the phone that will ask them questions that will help understanding preferences. But we can also analyze the sort of data that we're picking up here for what's called revealed preference data. What are people actually doing in different contexts? To what degree are they actually choosing, when nearby a convenience store, to still go to the grocery store? To what degree is it driven? Does it seem to be driven by proximity as opposed to some internal preference, or as opposed to time of day, which is something I think Colin mentioned yesterday. Secondly, this sort of data can provide a database for what's called calibration. And this is one of the topics that I've left till this afternoon as an optional topic. It's a topic whereby, instead of putting data into a parameter in the model about a low-level assumption, we try to get the model's behavior to match the empirical data from the world. It's the model's emergent behavior, not the behavior of one parameter in isolation, but the behavior of the model as a whole or large portions of it. We try to match that against similar emergent behavior in the world. That data we have about the world often isn't enough to allow us to boil down to estimate a particular parameter, or often we'll have data from the world that isn't about one parameter. It's about the interactions of the system as a whole. It's the emergent patterns that we see, and we can try to calibrate a model to the data we see from these data sources via the phone to better improve that model, to make it more responsive, to make it more accurate, more grounded in actual empirical observation. Dynamic models, of course, once informed in this way, provide huge additional value to the data. The data by itself, without models, is nothing more than a cacophony of numbers. It's large-scale streaming sets of numbers that, without models to make sense of them, are more or less meaningless. The models provide a way, the dynamic models provide a way to link, for example, the implications of this data to decision outcomes, to ask the implications of this data for, say, the trade-off between policies, between interventions, and it can help explain regularities that underlie the data, can help explain dynamic hypotheses that best explain what we see in this data. And it can help us understand the proximal and distal implications down the road of this observed behavior, say, on weight outcomes. So if we see differences if we see over time, for example, certain types of behavior involving food procurement and types of behavior involving physical activity, we can put those into a model and ask what is the implication of that over many years in terms of weight outcomes, particularly if it's supplemented by things like heart rate data from smartwatches. Finally, these models can perform a very valuable tool by helping us to determine how quickly we have to measure the data. So it's not just the data informs the models. That's a lot of it. But the models actually inform what data to collect, how frequently to collect it. Okay, couple additional things here, and I want to bring this to a close before dwelling on it sometimes. There's also a big component of what's called classification models for this. And my group spends a lot of its time these days refining models that we've built up to do classifications of people's health behaviors or environment. So we have models that will classify, for example, is someone sitting, standing, lying down over time? Because there's much interest in the literature now on the impact of sitting versus standing, for example, even if fairly sedentary otherwise. To classify even whether the phone is on the person or off the person, that's a fairly straightforward one, but it takes into account several measurands. For example, is the phone plugged in? Is the phone horizontal or not? What's the level of acceleration on the 3 axes of the accelerometers? Some additional information could be used as well. And based on what are called machine learning models, and there's a particular type called hidden Markov models, which help you understand in a temporal context the likely state someone is in, we can classify whether the phone is likely to be on their person or off person. We have similar models for whether they're in a vehicle or not at a given time. So is the acceleration measured their own acceleration, or is it mostly the acceleration of a vehicle around them? Are they indoors or outdoors is another category. Are they smoking or not smoking? Going forward, are they using an e-cigarette, smoking, or neither? These are things that we can use automatic classifiers based on the sensor data to classify. And once we have these classifications, we can use them to better calibrate or parameterize a dynamic model. We can ask what fraction of the time or how frequently do people smoke, for example, using that data from the classifiers we have, and we can cross-check it with their self-reports asked for a given study. So here, we are using sensor data together with models, and one of the key value adds here is the ability to deepen learning from interventions. So it's this ability of this data to pick up particular pathways. To what degree, for example, is someone who moves from a mixed income to a mixed income neighborhood, to what degree does their moderate to vigorous physical activity change from what was recorded before that move? Or their sedentary behavior? To what degree is their time spent at home changing? To what degree are they traveling to old neighborhoods, which has been used as an explanation for why teenage boys actually exhibited adverse criminal involvement indicators for the moving to opportunity study? To what degree are they really taking advantage of neighborhood food environment in terms of going to grocery stores? To what degree are they still going to convenience stores? Those are things that we can resolve in terms of the phone, and we can know in terms of neighborhood walkability, where are they spending their time? Is it this section of the city or that one? What's the level of walkability seen for each? What are the crime indicators here? We can ask them about their perception of safety in different regions. And we can look at the recreational space availability based on where they're spending time. So really it's filling in this sort of diagram that we can do increasingly using this type of big data. It's not perfect, it has its shortcomings, but we can increasingly fill in the gaps. Now, the exciting thing, ladies and gentlemen, is that is a very similar thing to what dynamic modeling can do. Because in dynamic modeling, we often capture multiple pathways. We posit behavior along multiple pathways. Think about the model we built yesterday, right? We had influence of people's food environment on shaping their procurement behavior, and we also had what they have in the fridge affecting what they eat over time, and we had some impact captured for park distance on their physical activity levels. We were, in short, capturing the impact of multiple pathways. By capturing empirical data on these things for interventions that have been put into place and comparing it with what the model thinks will be the case for those interventions, judged prospectively, we can improve the model. We can find gaps in the model. We can use the data from the devices to further refine our theory about what's going on and what's driving it. We can also identify which of these pathways we are nudging properly, which of them we're bending the curve, and on which of them we are falling short. And through that, and through use of a dynamic model that incorporates those results, we can then find an intervention, an alternative intervention that will seek to change that vulnerability, will seek to improve multiple pathways, not just the one that we were on which we were successful. So, ladies and gentlemen, this issue of learning more quickly and deeply from interventions, I argued earlier that that's something with which dynamic modeling can help. Models help us learn from our experiences more fully and try to figure out what does that mean in terms of getting even better. And that's a big use of models, but that use is strengthened so much more if we have actual empirical data, because we can figure out where did the model go wrong, where was the model off, or how can we do better next time by using the model to ask about other counterfactual interventions that aren't yet in place. And so we can identify shortcomings of the model, and we can identify ways to improve the intervention using this confluence of the model to ask about counterfactuals and to compare with this data and the empirical data, which pins down many things which erstwhile were the subject of speculation. So when it comes to improving our learning from interventions, I see modeling and this sort of data as working hand in glove to improve our understanding, to give us that kind of picture of what's going in between the traditionally coarse indicators of outcomes that we have and the intervention itself. If we can fill in these pathways with greater reliability than what we can get with self-report, we can do a lot better in formulating new interventions, and modeling is part of that process, and the sort of data that we get here is part of that process. They both work together in this way. So in short, we can help identify primary reasons for lack of intervention success, and cases where effects are being felt in some pathways, but they're not yet being felt in the outcome. These are things that models can help us anticipate, there's a time constant, so you shouldn't yet anticipate effects on an outcome, but we can identify empirically cases where that's indeed the case if an intervention is in place, and we can identify cases where pathways are changed but working at cross purposes. And bleed-through effects. We know that, for example, when we have design studies where there are intervention groups and control groups, it's not always so neatly done. And we have cluster randomized controlled trials where we'll try to account for this. But the fact is that when it comes to social norms, when it comes to communicational behavior, knowledge, attitudes, and beliefs that are communicated, there are often effects where things that we undertake with respect to an intervention group bleed over to control groups over time. And we can pick up aspects of that using these sensors and try to reason using a model about why that may be taking place through the social networks, etc. So, here, in terms of learning from interventions through dynamic models, we can compare the collected data from devices, self-reports on those devices, sensor data, proactive self-reporting using the crowdsource functions, to just sort of compare it with dynamic model results to help calibrate, parameterize the model better, to help enhance model hypothesis building, and to reason about the impact of alternative interventions that will do even better than we have with the one that we've had in place. So when it comes to community-based interventions, which are often adaptive in their character, there's a great potential here for informing things. More than that, there's a potential for getting the community involved in shepherding its own data. And this has been a big point of emphasis in a lot of our work the potential for allowing the community to get access to the data collected about the community at an aggregated level, and for individuals to compare their own data and what's been collected with them, from them, to that for corresponding groups in the community. This is a type of functionality we provide much of right now, and it's a big push that we're making, particularly for our Alberta partners. So I won't go into some of the classification components. I think I'll go here and wrap up with a few additional comments. One thing is that this sort of data going forward, combined with dynamic models, can be used to deal with shortcomings of models. There's a set of techniques in the statistical literature called sequential Monte Carlo techniques, or particle filtering, which can be used to take incoming data and use it to constantly update a model's understanding. And this can yield even an extremely inaccurate model, and I've shown an extreme case here, where when new data comes in, the model is regrounded, and it then projects forward from that, and then it's regrounded, projects forward. And this data can kind of keep a model honest. It allows you to build a sort of rough and ready model and keep it constantly regrounded with data. This is a case where a model's been given the data to time 35, and then been asked to project forward after that. And the data that's been given already is sort of clued it into what's going on enough that it can anticipate what lies forward. It has many particular hypotheses for what lies forward, each captured in something called a particle, and we can use that to sort of anticipate ranges of uncertainty about what might be going on looking forward. And these sorts of approaches, when you have incoming data at high velocity, they can provide tremendous insights with the models. Some of our work has identified cases where the sort of data that's coming in, this high resolution data, is actually needed to make an informed, an accurate decision. Without this data, we find that the model results are way off, and we really need resolution for certain types of questions, resolutions of, say, collecting data every 15 minutes to capture the spread of a fast-moving infection like Norwalk virus through a facility. Without that, our model projections go quite far off, but with that sort of data on contact patterns to this point, we can actually give much better understanding about what's likely going to be going on in coming days. And to do this, we've used data knockout experiments where we've eliminated some of the data and see how does that affect the accuracy of our modeling. I don't think I'll go into that, but I just want to comment on some conclusions here. So, broad, big picture. Empirically grounded models require data to inform them. That's almost their definition. And while we're often using these models to look into counterfactual situations, it is highly desirable if we could have some data to tie them down at first. Now, sensor-bearing devices are increasingly ubiquitous. We carry them with us every day, devices with dozens of sensors. And these devices, such as phones, can serve as versatile sensor, ecological momentary assessment, and crowdsourcing platforms. These devices that are as prosaic as our phones can be really powerful tools for eliciting understanding of health behaviors from individuals. And our observation has been that people are willing, from many different backgrounds of life, to really engage with these devices and actually offer up information proactively that's really quite impressive. It turns out that because of the sensors on the device, you can pick up lots of information about your context, where you are, with whom you are, how long you've been there, that can provide a lot of understanding of influences that might affect health behavior and health outcomes. Coupled with dynamic models, this sort of sensor data can offer really significant and complementary health insights. And cross-linked sensor data and EMA data from these self-reports, as well as these ecological momentary assessment surveys, as well as other components of big data such as weather data, data on pollutant levels outside, data from GIS databases about the nature of the environment in which you're detected as moving around. if you link these up, these can offer tremendous potential to complement and sharpen traditional data sources and traditional methods. And they can provide a profound source of data for informing dynamic models, which would otherwise be short of the data to really inform theory within them. And use of machine learning techniques like particle filtering as well as hidden Markov models and others can really enhance the power of dynamic modeling. And a key use of this data for social and health policy to allow for benefits is to learn more quickly from interventions. Whether they're successful or not, they can be successful in terms of learning better what would make an even more effective intervention. In terms of leveraging what we do see to come up with something that's far less vulnerable to oversights and that achieves far more. So these are just some conclusions from this pack, and I'd like to provide my acknowledgments for this work to many people who have made this possible, including many funders, Kevin Stanley, who co-leads the work with me, and partners at a Public Health Agency of Canada, American Legacy Foundation, NIH, and elsewhere. Oh, thanks very much, Dylan. Much appreciated.
While I have you distracted, what time do you want to have lunch at? Are you on track for 1 o'clock?
It depends. When could they have it ready?
I can go ask, just whenever you prefer.
Yeah. I think we could do another session if we did it at 1 o'clock. Would people like it sooner or later?
Later.
Later, 1? Okay. If you could let them know 1, then that would be great. Yeah, Chris.
One comment, a couple of things about the data. Firstly, you're relying on people choosing to take part.
Yes.
And
correct.
So what do you do then about that volunteer bias? Because presumably the people who want to take part in this are likely to have different
Indeed.
health behaviours than the people who don't.
Yeah, it's quite right. And we've had to deal with this in a substantive way for some of our collaborations. So the first thing is this is not a magic bullet, right? I mean, it doesn't totally, it's not like I'm saying this should be used instead of traditional approaches at all. Indeed, there's going to be some people who may respond better to random digit dialing still than this sort of approach. It tends to be, there tend to be demographic categories. Our partners in Alberta who run this yearly program for the ACPLF, the Alberta Cancer Legacy Prevention Fund, they say they actually pick up with random digit dialing a strongly declining number of people, but those that they do pick up tend to be clustered in certain age groups and actually tends to be older retired individuals. Women are somewhat overrepresented in it. And by contrast, I think the group that we're getting here will be of rather different demographic. It includes many young people that they have a very hard time reaching because they don't have landlines in the first place, or they just screen out calls. But it also includes many others. We've been surprised at the level of uptake from people of different ages. Much of our work has focused on youth. Much of our work has focused on people in their teenage years or young adults to their 30s. But we have had substantial success with older individuals. How do we incentivize them? Well, this varies study to study quite a bit. In some studies where we're working at really at-risk populations, we've typically given them the option of some participant incentives. So we're working right now with Harvard and with Trush Initiative, formerly American Legacy Foundation, for work in some low-income communities in Texas and Massachusetts. And there we are providing participant incentives in the form of data plan top-ups. So they can get a $70 per month data plan top-up, which will shield them from any costs if it's to be sent over the cell network. The system that we have, you can set it via a simple settings configuration. By default, it only sends over Wi-Fi to spare costs for the participant, but you can set it to send over the cell phone network, which means we get the data a lot faster, but we're providing top-ups as an incentives. For Alberta, we're providing no incentives. The incentives there are largely in part, they get access to their own data and they can look at that data and use it to compare themselves, benchmark themselves against others in their community of their age group in terms of the mobility, in terms of physical activity, sedentary behavior, those sort of measures. We're seeking to provide a way in which they feel some value comes from it. Now, you may argue, and I think you're quite right, that many people will be interested in that, but many people won't be interested in that, right? For other people, there's very low cost to being involved, and we're trying to encourage a sort of social involvement where we can actually get whole groups involved with some amount of kind of encouragement from others in the group. It remains to be seen fully how inclusive this will be. What I will say is that a tremendous amount of this data is collected with no disturbance to the participant at all. There are other cases where we have seriously considered, in which some partners are rather interested, where what we're proposing is basically only using this data if it turns out to be needed. You think about a foodborne illness outbreak, or you think about a case of a serious influenza year, or indeed a case of, I don't know if you have them here in Australia, but in Canada and in the States, there's a disturbing number of pertussis outbreaks occurring. Also some measles as well, because of declining vaccination rates. It's a scandal in many ways. You might collect some data from people. They might opt in so that their data is used only if it turns out to be needed for emergency purposes, in which case their data will go into escrow. It won't be used by default, but if there's an outbreak, only then will the appropriate authorities have access to it, and then they'll be compensated for it. So a major mode that we're looking at is providing an easy conduit so that a researcher or a health agency could easily provide some compensation, maybe it's 25 cents a day, to an individual to collect certain types of data. And a given person might opt in to several studies simultaneously. I happen to be right now in 11 studies on my phone, and you're welcome to look at it if you're interested. They keep me busy answering questions, but the point is that it's, in terms of my sensor data, if it's going out to one, it might as well go out to another, and I'm perfectly happy to have it do that. So we provided, in short, financial incentives in terms of kind of community spirit, trying to encourage people in a spirit of kind of contributing to the healthcare system. That's being used. Another thing is comparing themselves against others, being able to kind of get a sense of where they fit into the broader system. We've also, in cases in the past, we've done things like raffles or other things to sort of provide people with some sort of incentive to opt in for personal gain. But we've been surprised, given this, just how much people are willing to support. I mean, it's amazing. I wish I could show you some of the things. For ethics reasons, I can't, because of the level of security we've been providing to people. But it is really quite amazing to see what people are willing to report on a day-by-day basis proactively. I'm talking about photos of all their food. I'm talking about photos when they will go and feel ill or weigh themselves or what have you. So, in this case, you see really very, very large differences in terms of what people are willing to represent about their day-to-day behavior for a very modest type of encouragement. And really, that's one of the things that makes me most encouraged about this. About this work, that we seem to be tapping into a certain willingness of people to tolerate a few questions each day, as long as they're really quick to answer, takes less than a minute to answer a given survey, they're willing to do it very freely. And that's encouraging compared to, random digit dialing where you're getting them on the phone for long periods of time.
And do you think there might be an issue then in I suppose, a reporting bias? Is someone more likely to take a picture of their food if it was a salad rather than a Big Mac?
Right. Yes. And what we try to put into place here is we try to have questions for people that will cross-check some of the data. So there'll be a certain amount they proactively report, and then we'll trigger EMAs occasionally, which might ask, a little bit about their food consumption, which will cross-check the completeness or the accuracy or the timeliness of what they've reported previously. And what we found is that we can spot inconsistencies then and use them to sort of flag certain data that look suspect or certain individuals. We do also provide proactively participants with a way of sort of saying stop data collection now and start it later to try to distinguish cases where someone is just not responding because they're too busy from cases where they want privacy. And being able to delineate privacy seeking from non-compliance for other reasons is valuable to get insight as to what will enhance participant response. One of the things we're also very interested in pushing on in the next year from a machine learning standpoint is what can we identify from the data the context for particular individuals or for groups that best motivate them to answer a question. So for example, it may be that a question phrased during the midst of a sedentary period is much more likely to be answered than one that occurs in the hustle and bustle of the day, while you're moving around or while you're in a vehicular context or while you're in the company of a bunch of other people. Maybe you're less likely to answer it. So if we can identify cues for that, we can better enhance the chance that a given question can be triggered at just the right time based on the sensor data. And so that's one of the things we're really working at. And again, that will better cross-check the completeness of their self-report. What I would observe informally is that we have, I think now, I'd have to do calculations, but certainly it might be in the low thousands of reports of meals, for example, on a daily basis or many times each day when people eat snacks, etc. And this has been going on for months as part of this foodborne illness study. And we're going to have an even bigger rollout of a larger study in January on the same topic with PHAC. And there, it's just amazing what people are willing to take pictures of. It's not the most appetizing thing. And this, frankly, it's a bit of a reflection of the fact that our societal norms, and I think I could say this, in a global sense, the societal norms are changing with respect to privacy. And I'm not saying it's good or bad, but what I'm saying is people are willing to share a lot more information publicly than has traditionally been the case. If you look at what's on Facebook, if you look at what comes out on social media, what people take photos of on Snapchat or Instagram or what have you, it's amazing what people are sharing, and particularly for Facebook status updates. People are willing to include all sorts of information that would have never been shared, I think, a decade ago or 2 decades ago. And so our hope is that systems like this that provide this really the 4 V's, the big volume, the velocity, the veracity, and the variety, they'll fit into the ecosystem in a way that might enhance our data availability. They're not going to be a silver bullet, but they'll be an important component. And I do expect Alberta Health Services might run a small RDD program for random digit dialing going forward. But a lot of it, what they'll be getting is a panel, a cohort of people carrying phones who will be opting into different questions over time for different studies that Alberta Health Services drives, and that will serve as a big source of data. Any other questions? No? Okay. So maybe what we'll do now is then we'll switch gears and